And now it is my pleasure to begin our forum with Dr. Schor. You have Dr. Schor's bio and all of the bios in your handouts. But let me just say that in addition to being the Vice President of the Commonwealth Fund, Ed is also a pediatrician, a former medical director for the state of Iowa and the Chesapeake Plan in Baltimore, and has been a program director with both the Kaiser Foundation and the New England Medical Center. So please join with me in welcoming Dr. Schor here. Ed? Sit up here and I'll just here.
I'm heavily mic'd this morning, but pediatricians tend to be soft-spoken, so that's probably a positive thing. Good morning. I'm very glad to be here. Richard said almost everything I was going to say, so let me walk through some of the points. The title that was given to me, or I chose for this, is U.S. Variations in Child Health System Performance. And variation, I think, is one of the key words. One of the things we found from the work we did is there is enormous variability from state to state. As a pediatrician, I find that fairly abhorrent, that the kind of health care you have available to you depends on where you live in this country. The second is, this is about child health care system, not about children's health care. My colleague Renee Jenkins will be talking about the status of child health, and so I'm not going to touch on that too much. First, let me set a context. Most of you know this, but lots are not from the healthcare field, so let me walk through this a little bit. This is a graph that shows two things. One is the per capita spending for healthcare in a number of countries of the world. And as you can see, the U.S. has the notoriety of having the highest expenditure per capita for healthcare in the world. We also have, among the developed countries, the highest infant mortality rate in the world. So one is led to wonder what it is we're spending our money on. I can show you a very similar graph that would look at life expectancy, where, again, we are lowest among some of the developed countries and still spending a lot of money. The Commonwealth Fund, my colleagues did an international comparison. We do surveys every year or two of a variety of countries, looking at their healthcare systems and at the comparing it with ours, looking what they might learn from us, but largely what I think we can learn from them. One of the things I want to point out is in the column over to your left, the categories that we use. Now, any of you who've done survey research know that you kind of think about the categories of data you want to collect, and you identify indicators for those and collect that kind of information. There's something relatively conceptual about this. We think it makes sense, but I'm going to come back to this kind of how you go about this kind of measurement later when I talk more about children. But we looked at quality of care, and for the adults, whether they got the right care, the care was safe, it was coordinated, whether it was patient-centered, whether we looked at access to care, we looked at the efficiency of the healthcare system, equity of access to healthcare services, and the degree to which people in these countries led long, healthy, and productive lives. And as you can see, there's some patterns. Australia, well, let's look over at the United Kingdom. Kind of a mix, but a lot of greens, which means it was among the best of the countries in terms of ranking. Australia kind of in the middle, and the United States and Canada not faring so well. Now, this is data that is not healthcare data. This is from the Foundation for Child Development that does every so often puts out a report on international comparisons of children and youth in terms of their well-being. And you can look at the bottom categories and see the U.S. falls in the middle in terms of children well-being among these English-speaking countries. One of the reasons I wanted to put this up here is, again, there is variability, and we need to be cognizant of that. But also to make the point that children's health status is not merely, in fact, probably not primarily a function of the healthcare system, but of the social determinants in the societies in which they live. When we think of healthcare systems, we ought to be thinking about what is it it's supposed to be accomplishing. Children's healthcare needs are different, particularly young children who are in the throes of their development are very different than those healthcare needs for adults. And so the system of healthcare for children and adults has some differences that ought to become apparent. First of all, children are actively developing more so in their early years, and so having a healthcare system that focuses on early development as well as adolescent development is quite important. Not something we think of much in terms of adult health. Preventive care is a big part of child health care, and in many regards it's actually a mandated thing. You cannot enter school, for example, except for certain exceptions, without being fully immunized. There's very little mandated for adults. Health care for children is parent-dependent. Very few children, even adolescents, go to get health care by themselves. And so we have another figure in the process. So how does the health care system address the role of the families in children's health care? Unlike adults, who tend to be characterized by the plethora of chronic diseases that they have, sometimes multiple, chronic diseases in children are actually quite unusual. And there are very few chronic diseases that affect a large number of children. Asthma is one, attention deficit hyperactivity disorder is another. Once you get past that, you're down to 1% of children or less having any particular chronic condition. So chronic conditions are important for those children. They contribute to high healthcare expenditures for children, and yet they don't drive the system. Prevention does. Because we've accomplished control of many infectious diseases in this country, which used to dominate child health care systems, we are now having the opportunity to address what we call new morbidities. These are social morbidities, drug abuse, teenage sexuality, learning disabilities, attention problems, behavioral disorders, and so on. That has shifted the nature of the care of children, but the system hasn't kept up with that. So we don't have a system that's good at the new morbidities, even though that tends to be what the majority of children's needs are centered around. And finally, children are the group with the highest poverty rate in the country as a population group, and they are particularly dependent on public financing for their health care. So the health care system that we think about for children has to take into account all the effects of poverty on children's health and development, as well as take into account their dependence on public financing. The major source of public financing for children in this country is the Medicaid program. It's an entitlement program based on family income. Overall, about 30% of children in the United States depend on the Medicaid program. It's higher for young children. In some states, over 50% of children in the first 5 years of life are having their health care paid for by public funds, particularly Medicaid and the SCHIP program. One of the things this means is the state is the dominant player in the health care system for children. States also are the entity that licenses insurance companies. Insurers are licensed to operate by states. Professional societies like the American Academy of Pediatrics are organized by states. So states have a much more important role in child health care than they do in adult health care. As we all know, states are under increasing economic pressure. Currently, over 30 states are expected to be in a deficit, projecting a deficit for their budgets for this coming year, since states have to balance their budgets, unlike the federal government. They're going to start looking for cuts. And unfortunately, the non-voting population, meaning those under 21, are likely to suffer some of those cuts the most. That's kind of ironic because At the time of economic problems, more people are impoverished, more people depend on publicly funded services, particularly children. We're going to see the ranks of Medicaid eligibility increase, while the pressure to keep those dollars low increases as well. One of the realities in states is that if you're a healthcare provider in a state caring for children and being reimbursed by Medicaid, your reimbursement is considerably lower than if you're a healthcare provider in a state providing for an adult who's covered by Medicare. This is consistent across virtually all the states, but not all of the states, where you see that the average, you can see, let me see if this, maybe this next slide has it. If you take Medicare as 100% payment for Medicare, the top 5 states actually pay more than the Medicare rate for Medicaid, but the average is 72% of a Medicare reimbursement, and New Jersey is very near the bottom at 34%. So it's better to be an elderly adult in New Jersey who votes than a poor child who doesn't, and it's better to be an internist or family physician who's taking care of adults than a pediatrician or a family physician or a nurse practitioner who's taking care of children. From an economic point of view, that has implications for access, and we'll talk about that in a little bit, but again, it highlights the variability. If you look at who's eligible for Medicaid in each state, there are certain federal minimums, but many states have gone beyond that. But from this graph, you can see, this chart, you can see that most states are staying pretty close to the federal minimum in terms of which children are eligible for Medicaid, with some exceptions. Who's receiving, those children who are on Medicaid, okay, they've signed up. Then the question is, do they get the health care to which they're entitled? And as you can see here, there's also enormous variability. There are 5 states where 80% of the children have had a preventive care screen, well child care visit. These are for 1- and 2-year-olds during the past year. Many more children are in the 60 to 70% range of having had true access to the healthcare system. So having an insurance card, if you will, does not guarantee access. One of the issues is who's taking Medicaid patients or who's seeing children. In New Jersey, 13 of your 21 counties are listed by the federal government as health provider shortage areas. So but we also know that even where there are healthcare providers, a large number may not be taking publicly funded Medicaid patients, and you saw the reason for that in terms of reimbursement. Here's a little more data showing the reimbursement variability. This is for a preventive visit for an established patient less than 1 year. The highest state pays $107, almost $108 for that visit. The lowest state pays about $20 for that visit. Again, where you live depends on what you have access to in this country. I was reading some stuff on New Jersey and discovered that the governor last year tripled the reimbursement for children's health care services in New Jersey, from $23 to $73 for a pediatric visit and $18 to $64. And I thought, wow, this is great. This is going to be an easy talk to give. And then I said, oh, wait, this is just the fee-for-service kids. And only 17% of the kids in Medicaid in this state are fee-for-service. The rest get the care through managed care organizations who at this point have no obligation to pass through these dollars to the healthcare providers. So this is encouraging, but there's still steps to be taken. One other national contextual thing I want to point out is that there have been some studies on the quality of healthcare in the United States, studies on adults, studies on children. This is a study from RAND. They've had a well-tested methodology where basically they say, well, if you're going in for this kind of care, this is the list of things you ought to have happen during that visit. And then they go and look at medical charts to see what percentage of those things that you really should have actually happened. And what you see is you've basically got less than a 50% chance of getting all the right care if you're a child. And the lowest chance of getting all the right care at a given visit is for preventive care, which is one of the hallmarks of child health care. The Commonwealth Fund did a study a number of years ago, or 1 and a half years ago, I guess, looking at adult health care in the United States. So then we thought, well, why don't we do the same thing for kids? And so we published this state scorecard. You no doubt can't read all that, neither can I. But this is the ranking of all the states and the categories, and I'll go through those in a little more detail in a minute. But one of the things I want you to see is that the states at the very top in the white tend to have lighter colors across all of the measures, and those that are at the bottom tend to have darker colors and lower ratings. Now, obviously, there's a patchwork here. There is no state that is number one or top rank or virtually bottom rank for any of the indicators. So every state's doing better and worse in some areas or others. In fact, Iowa, which ranked the number one state, is not number one in any single category. Now, part of this is the methodology, which is admittedly one of convenience. I want you to also see that there's some kind of regional patterns in terms of where states fall in terms of quartiles for their performance. And we can talk about this later. This is too detailed, but let me walk through. There are 5 categories we chose. There is very little state data on child health and health systems available. Very little. It's another reflection of the low priority I think children get in this country. So we didn't have many things we could actually pull from that we thought were uniformly consistent data. We wound up with 13 indicators, which we clustered into 5 categories. Access, which is composed of the proportion of children who are uninsured and the proportion of low-income children who are uninsured. Quality, for which we had 7 different measures. The first one was that children are getting all the vaccines, the doses they're supposed to have. The second was that they've had preventive care visits in the last year. Third was that children with emotional, behavioral, developmental problems actually get care for those problems. The fourth was that the children have a medical home, at least a regular source of medical care. The fifth was that children who need a specialist's service, that their doctors follow up to see that indeed that had happened. The sixth was children who need a specialist service. Did they have any problems getting that specialty referral and getting to that specialist? And finally, we looked at hospital admissions for pediatric asthma. The third major category was costs. There is no data on the cost of child health care in the United States. So what we did was we took 2 variables, the state total personal health care per capita spending, okay, so that's adults and children, and the family premium for an employer-based health insurance package. So we use those 2 variables. The potential to lead healthy lives, this is, I think, kind of not conceptually tight, but we looked at the proportion of young children who are at risk, high risk for having developmental delays, and the infant mortality rate in each state, excuse me. And finally, we looked at the issue of equity. And this was the likelihood of having either a medical home or a preventive care visit influenced by income, race, ethnicity, or insurance coverage. So here's the major categories again: the potential to lead healthy lives, access, quality, cost, and equity. Comparing the rankings for the 3 states in this region, New Jersey, New York, and Pennsylvania. You can see that New Jersey ranked last. If you look, it really is the access indicator that really brought things down. This is an average. So compared to New York and Pennsylvania, access for children in New Jersey seems to be the big issue. Access is quite variable across the country. Again, white is the best access, dark is the lowest access. It looks much like the map I showed you on overall performance. So access is kind of the bottom line. You know, if you can't access healthcare, you can't have good quality healthcare, you can't have equity, and so on. So access is truly an important factor. After our report came out, I got a lot of media calls and some calls from political representatives. Almost all of those calls came from states at the bottom of this map. None of the states that were in white called me. So let's look at a couple of things, New Jersey specific. Here's the access one. And remember, access is the percent of uninsured children and the percent of uninsured children whose family income is 200% or below of poverty. I think what's really important, again, is this variability. The best state is about 5% of kids overall are uninsured. The last uninsured children, the worst state had 20% of children uninsured. This is a regression graph looking at states' ranking on access plotted against their ranking on quality. And as I pointed out before, obviously they're linked because you can't have good quality unless you have good access. But it's a fairly strong relationship. Here's the state's ranking on quality. Again, the map looks kind of similar. There's states that do bounce around from quartile to quartile. Let's look at New Jersey specifically for a couple things. One is the percent of children who received both a medical and dental preventative care visit in the past year, and this was 2003 data. New Jersey actually scored better on this than the national average. So only 31.7% of children in New Jersey didn't have preventive care last year. I'm being facetious. There's, again, huge variability between the top states and the bottom states. And as you can see, being in poverty, the green lines, the children whose family income is 400% of poverty or higher, where about 70% of them had preventive care in both those categories. If you're under 100% of poverty, 48%. So poverty makes a difference. And as you can see from the blue lines, having insurance, private insurance versus being uninsured also makes a difference. If you look at the issue of having a medical home, children who had a personal doctor or nurse where they received care that was accessible, comprehensive, culturally sensitive, and coordinated, New Jersey came out ahead of the national average there. Again, large state variability between the top 10 and the bottom 10 states. Poverty, again, a powerful factor. And clearly insurance was even more of a factor in this indicator. If you don't have a way to consistently pay for your health care, you probably don't have consistent health care. Another thing to look at is the hospital admissions for pediatric asthma. In the poorest state, there were 314 admissions per 100,000 children. In the best state, only 54 admissions. Now, some may say, well, you know, we live in a very polluted area and so kids have more asthma. Well, I would say, you know you live in a polluted area where more kids have asthma. We can prevent asthma hospitalizations. This is an indicator that even though you know your children are at higher risk, you're not doing what you should do about it. States vary in terms of the cost of care. Now here, best cost, top quartile, is the lowest cost, whereas the bottom quartile is the highest cost. Now, I think saying best and worst doesn't quite fit in this way. Healthcare does cost money. Spending more to some extent will get you better access to healthcare. There becomes a point where you spend more and you don't get better access to healthcare or better quality of healthcare. And looking at that international data I showed you, the U.S. has passed that point long ago. Nonetheless, financing health care is an important consideration. This is the data on the average family premium for employer-based health care. And there's a $3,500 difference in cost between the best state and the most expensive state in this country. Now, assuming that these insurance benefits are equivalent, you can do that math yourself and draw your conclusions from it. The state rankings on potential to lead healthy lives, variable. The picture looks a little bit different than it did earlier, and what you see is probably dominated by infant mortality. The southeastern states are doing more poorly in that. If you look at the variable of the children at high risk for developmental delays, again, we have almost a twofold difference in this category among states. And this reflects some of those social determinants I mentioned earlier. It reflects family income, reflects early childhood education opportunities, it reflects parent education, it reflects the community opportunities that are provided for children. Most developmental delay in this country has a social origin to it, not a biologic origin to it. If we look at equity, we find, again, great variability. Let's look at percent of children with a preventive care visit based on family income as the variable, looking at the gap that income can play. And you can see that based on income, we had considerable gaps in this variable. So Richard had talked about if we as a country address some of these things. Let me talk about specifically New Jersey. We went back to that original thing and did the calculations. Found that if all children in New Jersey were insured, you'd have 153,000 more children covered by health insurance and therefore more likely to receive health care. If all young children received the vaccinations for which they should be getting, you'd have 26,000 more children fully vaccinated and less likely to contract infectious diseases. If all children had both a medical and dental preventive care visit, that would be 141,000 more children every year would have preventive care. If all children had a consistent source of medical care, it would be 177,000 more children would be affected in New Jersey. If children with special health care needs who needed a specialist no longer had problems getting referral to that specialist, about 10,000 fewer children would have that difficulty. And finally, if the factors that are affecting children's developmental delays were addressed, you'd have 76,000 fewer children who would be at risk for developmental delays. The savings to the education system in the state would be considerable. So what are the lessons we've learned from this and things to think about? First of all, child health care is largely a responsibility of states. This enormous variability is a problem. Where we see variability in quality or access or anything else means that somebody's doing it better and somebody's doing it worse, and we can learn from the ones who are doing better. The fact that there are these gaps, that there are these differences, I think makes a compelling case for the need to address these problems. These differences reflect policy choices by states. Since child health care is largely a state function, the way to address it is largely through state policy. When I was asked by those lower tier states, radio and TV stations, why they were there, I said, I don't know, and I can't actually give you the answers. There's people in this audience much better prepared to tell you why New Jersey is the way it is than I can. But I said, I happened to live in Iowa right before we did this, and Iowa came out number 1. And I can't take all that credit. But reflecting back on it, I thought, well, why was Iowa so good? And people ask me about Iowa, and its politics are really kind of interesting. It's a fiscally conservative state and a socially progressive state. And Iowa has put huge priority on schools, on health care for children. They're working very hard to improve the early education program for young children. It's very family-centered. Family support services are readily available. When I went to talk to legislators about early brain development and children's needs for things, either side of the aisle, if I could couch it in terms of families' needs and children's needs, I got their attention. So I think I can't say that I was different from other states because I don't know the other states, but I can say that at least in Iowa, children are a priority. And I think that's reflective in their rankings. Universal coverage matters. You know, when you have some kids with and some kids without, things get pretty chaotic. And we know kids go on and off of Medicaid, so it's kind of a mess, and that makes it that much more difficult to make sure children have what they need. One of the things children need is a regular source of care, a health care practice that knows them, wants them as their patients, and does a good job with them. And that's important because we know that having access to the right care at the right time matters. Now, just because you have access to that office doesn't mean you're going to get the right care. I showed you the data on quality, and we need to be addressing the quality issue all over the country. That's not specific to any particular state. Some are better than others. But nobody's doing a great job with child health quality, or for that matter, adult health quality. We have the best health care system in the world if you can buy it. But if you're in the majority of the families that don't have access to the top health care providers and ready access to those providers, you're not getting the best health care in the world. So my bottom line is trying harder, telling the doctors to work harder, telling the families to stretch themselves and get their kids to care is not the answer. It's the system is the problem, whether it's the political system, the health care system, the family support system, the medical care system. The system is the problem, and we have to look for systemic solutions. So thank you.
We do have time for questions, so I'll let Ed, you can field the questions as they come.
I'll try and be loud. I don't know how common the knowledge is that before the New Jersey legislature broke, that's okay, I'm pretty loud, broke in the summer, they passed a bill, and the actual words of the bill are that each child shall, and the word is shall, have health care coverage, and the effective date of that legislation is November 1st. I should say I'm a health care attorney for legal services. As of this moment, that's 2 weeks away, there has been no legislation from the health commissioner that says how we're going to accomplish that feat. So it beats the hell out of me how I'm going to press that, since there is no rules to press that. That aside, I think what you're saying is that even though there will be the mandate for the care, since we are so lacking in access in New Jersey, that's largely chimerical anyway. It won't matter all that much because there would be no doctors to go to, even if you have the health care. Am I reading you correctly?
Yes. But if the Medicaid program and other private insurers recognize what the governor's office did in terms of increasing the fee-for-service rates and develop in their contracts with managed care companies the mandate that level of reimbursement carries through to practices that are using Medicaid managed care, I think you'll find a lot of providers are going to start being willing to see these kids.
I was surprised to see the Canada down at the lower end of your scorecard with the United States. And there's a country that has universal coverage, single payer. What is their system problem?
See if we can scroll back quickly to that and see if we can dissect it a little bit. They certainly do have access. So that's even though it ranks poorly here, they do have the financial access. Part of it is it's a spread out country, so I assume that in the larger cities, they're going to look better than they do here. It's largely a farming, lumber, agricultural kind of country, so I think that's likely to have brought this down. Beyond that, I don't know. Maybe somebody else in the audience has an idea. Renee?
I had a presentation from Robert Walker in our district meeting, and he really talked again about wait times, the fact that when they have a card, it still doesn't, there's sort of a ration of that care. And so it seems like even though the care is available, it is not dispensed freely. I mean, you just don't sign up and go get something. You get on waiting lists for things. And so they've almost developed at some level a two-tiered system where you can go get care at the provincial system, or you can either cross the border and come to the States or go to private care. So I think they've had some issues trying to balance the need with what's available for their resources. That's the impression I got from Robert Walker's presentation.
One of my observations there is that although there's waiting lists, those are waiting lists for elective things. If you are in critical need of something in Canada, you get it.
So the basic things are definitely
The basic things are
yeah.
waiting.
We've been struggling with the issue of Medicaid copays, as in the state has been trying to impose them, and we've been fortunately enough the last 8 years to fight it off. I'm wondering about the impact of Medicaid copays in the other states in your study on parents taking their kids to the doctor. If you found anything on that?
Yeah, my understanding is that most state Medicaid programs don't have a copayment. You know, copayments are really a peculiarity. I mean, copayments are ostensibly imposed to give people pause before they go to the doctor, so that you decrease unnecessary care and unnecessary service use. So why you would have copays for an emergency room visit, for surgery, for preventive care, for prescribed drugs, doesn't make any sense to me at all.
Dan, did you have a question? And we can wrap up with your point.
I was going to actually make a point in response to Professor Rosenberg's question. People often use Canada as the example of why single-payer universal insurance is a failure and shouldn't be applied in the United States. But if you're an optimist, you look at the rest of the graph and you see that those other countries, all of which have some form of universal single-payer, do very well, do much better somehow than we do in North America. So it seems to be a North American phenomenon more than it is a matter of the format of the insurance.
Okay, I think that'll wrap up our first speaker. Thank you, Dr. Schor.